So assalamu alaikum to everybody joining us from Qatar and wherever you all are in different parts of the world. So good afternoon or good evening or good morning. So thank you for joining us today. I'm Dr. Sohaila Chima. I'm the Assistant Dean for the Institute for Population Health here at Weill Cornell Medicine in Qatar, and also an Associate Professor for Clinical Population Health Sciences. Fantastic to see so many people joining us today. We are very, very excited to have two wonderful speakers. But just before I introduce the speakers, just to remind everybody, the objectives of our population health and well-being series are to discuss contemporary and critical topics which are relevant to healthcare, medicine, and population health. We will also examine during the series evidence-based practices which are germane to public health and patient care, and then describe opportunities and challenges in the evolving face of healthcare and population health. Just some housekeeping, your cameras and microphones have been turned off. Please use the Q&A feature to type any questions and comments. You can also post your questions in the chat. We will be able to see them. So please feel free to post your questions or comments in the chat also. Questions will be addressed at the end of the session. And just so that everybody knows, this session is accredited. So by both ACCME and by the Department of Healthcare Professions, the accreditation section of the Ministry of Public Health. For evaluation and certificates, the post-activity evaluation should be available in your Cloud CME account by September the 21st. You'll receive an email notification once the evaluation is available in your Cloud CME account. And your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So here we are. The title of the talk today is Considering the Totality of Evidence, Integrating Real-World Data with Clinical Trial Data to Improve Decision-Making. We have two speakers for the talk today. So it's my honor and privilege to welcome both Dr. Ronac Mamtani and Dr. Rebecca Hubbard, both from the University of Perelman. I'll do a short introduction for both the speakers. So Dr. Ronac Mamtani, he's an assistant professor, hematology and oncology at the Perelman School of Medicine, University of Pennsylvania. He's a medical oncologist and cancer epidemiologist. His clinical practice focuses on bladder cancer, and he participates in Penn's multidisciplinary bladder cancer clinic. His research sits at the interface between population science and patient-oriented research and focuses on understanding the role of host factors on bladder cancer outcome. Dr. Ronac Mamtani currently leads an NCI-funded prospective cohort study which aims to identify metabolic risk factors for bladder cancer recurrence after cystectomy. He has particular experience using big data from large electronic medical record and administrative databases, such as the UK Health Improvement Network, the US National Cancer Database, Medicare and Medicaid, and Kaiser Permanente of Northern California and Flatiron Health. Additionally, he serves on the American Society of Clinical Oncology Scientific Program Committee for Health Services Research and Quality of Care and the Bladder Cancer Advocacy Network Scientific Advisory Board. Dr. Rebecca Hubbard, our second speaker, she is a professor of biostatistics, a senior fellow in the Institute for Biomedical Informatics, and a member of the Abramson Cancer Center at the University of Pennsylvania. She holds a PhD in biostatistics from the University of Washington and master's degrees in epidemiology and applied statistics from the University of Edinburgh and Oxford University, respectively. Her research focuses on the development and application of methods to improve analyses using real-world data sources, including electronic health records and medical claims data. Her methods have been applied across a broad range of research areas, including health services research, cancer epidemiology, aging and dementia, and pharmacoepidemiology. So Dr. Ronac Mamtani and Dr. Rebecca Hubbard, a very warm welcome to both of you. And I hand over the virtual mic to Dr. Ronac Mamtani.
Great, thank you so much for that amazing introduction. Let me share my screen. Great, hopefully everyone can see this. It is so exciting, you know, what an honor it is to be here to talk to you about a little bit about our research, which, as you mentioned so eloquently, focuses on using real-world data to improve patient outcomes. Here are my disclosures, and here are Dr. Hubbard's disclosures. But perhaps the most important disclosure is that Dr. Mamtani Sr. is my father, and he provided me with my very first exposure to clinical research in 1993. And so every morning, and I know he's in the audience, every morning he would drive me in New York on Springbrook Parkway, and he would drop me off at New York Medical College. And he would stick me in Dr. Lowenfeld's office. Now, many of you know Dr. Lowenfeld, who is really a world-renowned cancer epidemiologist and surgeon. And in Dr. Lowenfeld's office, I was forced to read paper after paper, all of which described the very first relationship between pancreatitis, which is inflammation of the pancreas, and subsequent pancreatic cancer. And, you know, at the time, this didn't have much meaning for me. But over the years in med school and in residency, I kept seeing the same paper. And it just illustrates, you know, Dr. Lowenfeld's incredible contributions to the field of medicine. And who knew, you know, nearly 2 decades later, that this would be the focus of my career as a medical oncologist and a cancer epidemiologist. And so, you know, just the other day, my mom asked me, well, what have you learned in the last 3 decades? And number one, I've learned that patients are incredibly grateful. This is a patient of mine with an advanced bladder cancer who sees me once a month from a GCC country near where you are. And his cancer is currently in remission. Number two, I've learned that decision-making for this patient and in all of oncology is very hard because it's not just about finding the best drug, but it's about finding the best drug for the individual patient. And as we'll learn today, you may not answer that question with randomized clinical trials, even though they happen to be at the top of the evidence pyramid. So I thought it would be really appropriate if we start by discussing and introducing you to a clinical case. Let me introduce you to Linda. So Linda is an 80-year-old Black woman who has never smoked, who presents with blood in her urine. And she had a CAT scan that showed a bladder mass that you can see in the picture below. And she also was found to have multiple lesions in her liver. And biopsy of the mass showed a urothelial cancer, which is a very common type of bladder cancer. And she's told that her cancer is incurable. She meets with an oncologist who tells her that her life expectancy is only 14 months with standard chemotherapy. And so my question for the participants today is this really true? And how do we know? Oncologists such as myself, we rely on clinical trials to not only inform patient decision-making, but also to inform their outcome, their prognosis, how long will they live? And Linda's prognosis of 14 months is derived directly from this study that was published more than 20 years ago. And this study found that patients with advanced bladder cancer treated with chemotherapy, on average, will live 14 to 15 months. But the problem is that Linda, who I just told you about, an older Black woman, is not representative of the participants in this trial, who were largely younger men who were white. And so this is a major problem. Also important is that Linda would not have even met the inclusion criteria of this study. Linda had poor functional status, and she had some kidney disease, all associated with age. And these are two major exclusion criteria. So she would have been excluded from the study. So results from clinical trials simply may not apply to patients receiving these treatments in routine care like Linda. And so Dr. Hubbard and I hope to take you through, number one, sources of real-world data and their potential to complement evidence from trials. And number two, we hope to present methods for comparing the effectiveness of a treatment in a clinical trial and a real-world population. And so together, we hope to address both the opportunities and the challenges in using real-world data to generate evidence that is missing from clinical trials. So I am not here to tell you that real-world data should replace clinical trials. And we all know that RCTs are the gold standard for testing treatment efficacy, sitting at the very top of this evidence pyramid that you see. But what I am here to tell you is that there is growing interest in real-world evidence, the rest of the pyramid. Physicians and patients in clinic will use real-world data in decision-making. You have heard that regulators, such as the US FDA, use real-world data for drug approvals or even vaccines, as we're all experiencing now. And industries, such as pharmaceutical companies, use real-world data to help design clinical trials. Now, real-world evidence really came to the forefront of medicine through passage of the 21st Century Cures Act. And this was a very exciting moment for us 5 years ago, because for the first time, they defined real-world data as data regarding the usage, the benefits, the risks of a drug derived from sources other than clinical trials. And this was actually signed into law in December of 2016. So why should we care about real-world data? Well, we should care because not all questions can be answered with clinical trials. Let me give you an example. 10 years ago, actually around when I visited Doha, 10 years ago, the US FDA and Takeda, a pharmaceutical company, approached investigators at Penn, including myself, and asked us to investigate the risk of bladder cancer in patients treated with pioglitazone, which is a common diabetes medicine. And this was based on some animal data showing an increased risk of bladder tumors in rats. And so we conducted a large retrospective study using a data set in the United Kingdom. And we found that patients treated with pioglitazone had a higher risk of bladder cancer than patients treated with an alternative diabetes drug. We presented the data to the FDA, and we were all surprised when, in fact, the warning label for the drug pioglitazone was now updated to include bladder cancer. And so this was a very motivating experience for me as an early stage investigator. But we should also care about real-world evidence because of what I alluded to earlier. So clinical trial participants do not reflect the broader population that we see in clinic. And this is because of strict inclusion and exclusion criteria that are implemented by clinical trials. And this leads to a very narrowly defined clinical trial population. So just to illustrate this problem, this is a figure that shows over time that there is an increase in the number and the complexity of these exclusions to the point where now we have 46 exclusions per clinical trial. And most of these exclusions are related to age and age-associated comorbidity. And so what are the implications of this? Well, I mean, over half of my patients in clinic would have been ineligible for the clinical trial that actually supported the approval of their treatment. If you look at this another way, clinical decisions today, all decisions today in our clinic are based on the very small proportion of patients that participated in these trials rather than the real world. So we should also care about real world data because large phase 3 studies don't include the outcomes for certain populations. So as you know, phase 3 studies are often powered to study drug efficacy in the majority population. And this means that there naturally will be low statistical power to study efficacy of treatments in certain patient subgroups, like women, like patients that have tumors with rare mutations, or like our elderly population, our frail population. And I know that this group recently published on the burden of age and cancer related to future projections. And so real world data can really augment knowledge from clinical trials. And I want to just walk you through 3 examples. So sunitinib is a common oral chemotherapy used for the treatment of kidney cancer, and clinical trials have demonstrated benefit. But these clinical trials have largely been based on men, younger men. And so in this study, we wanted to examine whether there were mortality differences among patients receiving sunitinib according to their age and according to their sex. And what we found was quite striking. Indicated by the arrow, we found that older women treated with sunitinib had higher mortality than younger women or men of any age. And so this observation can really be brought back to the clinic when we discuss the risks and benefits of these treatments with our patient. Here's another example. Many of you have heard of immunotherapy, which is a form of cancer treatment. Immunotherapy is approved for many cancers, including lung cancer. In this study, we wanted to know whether there were differences in survival in patients with lung cancer treated with immunotherapy according to whether or not they carried a rare mutation. And what you can see indicated by the arrow pointing to the red line in the survival curve is there is clear evidence of clinical benefit, improved survival in patients whose lung cancer has a KRAS mutation compared to those who do not. So another example of how we can use real-world data to inform a treatment decision. And finally, what I think is the most interesting example that Dr. Hubbard and I collaborated on recently is in this study, we wanted to know what was the utilization patterns for immunotherapy in patients according to whether or not they would have been eligible for the study that led to the approval of immunotherapy. And on first look, this seems obvious. After the FDA approval in 2015, naturally we see rapid dissemination of the treatment in the clinic. But what was truly remarkable is you can see uptake even among the patients that were ineligible for the clinical trial that led to this drug's approval. So in other words, we are seeing prescribing to patients where there is true uncertainty in the risk and benefits since there were no clinical trials. So now that we've established, hopefully, that real-world data is important, I thought it might be helpful to list a few sources of real-world data to study cancer outcomes for those in the audience that have interest in pursuing this. So many of you have heard of these sources. These include cancer registry data, administrative claims data, and electronic health record data that we will be spending more of our time on. And each of these data sets have advantages and disadvantages. So for example, cancer registry data such as SEER, they have very rich cancer information, including stage and certain molecular profiles, but they have limited data related to a patient's comorbid conditions or prescription information. Claims data, because they were built for the purpose of billing in the US, have excellent information on comorbidities and prescriptions, but they lack granular information on cancer. And then finally, as you'll hear, Dr. Hubbard and I feel that electronic health record data probably offers us the greatest potential to accelerate cancer research because they have very rich information on comorbidity, prescriptions, and cancer. And we'll spend some of our time focusing on Flatiron Health, which is a really exciting data set. Flatiron, I don't know if some of you have heard of this, but Flatiron is a very diverse and large data source for real-world evidence. It contains, 2 million patients with cancer across the US and across over 260 cancer clinics. And these clinics are both in the academic setting and in the community setting. And what's unique about Flatiron is that this data set produces longitudinal models of many different types of cancer. And the largest data set, which is the lung cancer data set, consists of more than 50,000 patients. And what's really unique and exciting about Flatiron is that they refresh their data sets every 30 days. And so particularly important in oncology, when we have new therapies, those new therapies are integrated in the data set very frequently, and there's minimal data lag. So how is this all done? Well, Flatiron combines elements from both structured data, such as the diagnosis, demographics, treatments, and labs, along with unstructured data elements, such as physician notes, radiology reports, pathology reports. And they do so through artificial intelligence and what they call technology-enabled abstraction. So they combine expert abstractors, so nurses, registrars, oncologists who sift through these medical records, along with Flatiron-specific technology or specialized software that helps the human abstractors to more efficiently organize and review some of those unstructured data elements to capture key variables. And so the product is high quality and completeness. This table on the left demonstrates the completeness levels for some key variables in the study of cancer outcomes. So the date of metastatic diagnosis, smoking status, histology, stage, and some other mutations. Now, when you're selecting a data set for cancer outcomes research, it is really important to understand the validity of the mortality in that data set. Mortality is a really important endpoint. And what I want to demonstrate here is that the accuracy of the Flatiron data set to capture death is reasonable, but it's not perfect. And you can see that clearly there's a degree of misclassification here according to the type of cancer. And this is an important consideration that Dr. Hubbard will discuss more. Also important to assess the generalizability of the data set that you are interested in pursuing. So here, if you look at table 1, we did something very simple. We compared the characteristics of patients with bladder cancer in Flatiron with those characteristics of patients in SEER. And what you can see is that the Flatiron population is very generalizable to the US population, similar age, gender, and close for race. Now, if you look at table 2, we do something a little bit different. So here, we look at patients who started immunotherapy for their bladder cancer in Flatiron, And then we decided to compare them to patients who received this treatment in the clinical trial. And what you can see is what you might expect, that patients in Flatiron were older, they were less likely to be white, they were more likely to be sick and more likely to smoke. So as we've mentioned throughout this lecture, the real world patients clearly differ from the clinical trial population. So I thought what I would do now is talk to you a little bit about some of our exciting research and review some applications of the Flatiron data set. You know that I'm a medical oncologist, and one of the decisions that I struggle with every day for my patients is how to choose between chemotherapy and immunotherapy. And I've listed some of the advantages and disadvantages of each. For example, chemotherapy has a much higher chance of response, but these responses don't last very long. And chemotherapy, as you might have heard about, or some may have personal experiences, chemotherapy has high toxicity. In contrast, immunotherapy, while it offers lower toxicity and long-lasting responses, the chance of responses is relatively low compared to chemotherapy. And so we have always had a hard time deciding between these two options because we didn't have any available data until recently. So something very interesting happened in 2018. In 2018, the interim results from a clinical trial were reported. And what was found, or what was reported, I should say, was a decrease in survival in some patients with bladder cancer treated with immunotherapy. Now, because these were interim results, no one saw the actual data. The data were not available to the public, but they were shared with the FDA. And so as a result, the FDA thought it would be best to issue a warning, and it made every headline in the US, alerting prescribers that there was a higher risk of death with immunotherapy. And so we thought this was the perfect opportunity for us to use real-world data to complement the clinical trial data. And our question was very simple. Did the FDA warning impact immunotherapy prescribing? And so what we did was we conducted a retrospective study using data from Flatiron, and we looked at trends in drug utilization. And what we saw was very striking. Prior to the warning in 2018, the use of immunotherapy increased quite a bit. We were all excited about immunotherapy. After the warning, prescribers were very vigilant, and you can see a decrease in immunotherapy utilization. And we went on to really quantify this change. And so here we calculated the percentage point difference in the observed probability of immunotherapy use and the predicted probability of immunotherapy use if the policy never occurred. And so what we found was roughly a 40% decrease in the use of immunotherapy. So you can imagine the FDA was very excited about this, right? Because their policy worked. And this later was accepted into JAMA, and it was a really fun collaboration with investigators at Penn, investigators in Flatiron, and the FDA. And it sort of exemplifies the first time where one has used real-world data to assess community response of an FDA policy. And you can imagine that this could have implications beyond just oncology. So let me give you the final example. This was an exciting study that Dr. Hubbard and I worked on. And so the next logical question here is, okay, is immunotherapy really detrimental to patient survival? And if so, by how much? Because remember, the warning was based on emerging data. No one saw the data. And so we thought maybe we can use real-world data to give clinicians a better sense of how they can inform their patients. And so we conducted a retrospective cohort study using Flatiron, where we compared treatment with immunotherapy and treatment with chemotherapy with the outcome of overall survival among patients with advanced bladder cancer. And this figure is a survival curve that shows on the x-axis time, and on the y-axis, the probability of being alive. And in looking at this, you can see that there is lower survival initially with immunotherapy in the first 6 to 12 months. And so if you look at the average survival, there's no appreciable change, but it's very clear that there is a detrimental effect of immunotherapy early on. And so you're probably wondering, well, is this what the FDA label would have been based on if they saw this in the clinical trial? What did the clinical trial show? So this was published in 2019. And we waited and we waited and we waited. And a year later, published in The Lancet, we see final results from the phase 3 study. And what you see should be a very familiar curve. Our results from the observational data were later reproduced by the clinical trial, more or less. And so this was a really exciting moment for us. It gave our research credibility. So let me just end by saying that I am not here to tell you clinical trials should replace real-world data. Clinical trials remain the gold standard for testing efficacy. But real-world data are important to provide information needed to plan clinical trials, to supplement information not available in clinical trials, to inform decision-making in the absence of clinical trials, and to answer questions just not amenable to being tested in clinical trials. But what I'll emphasize is that appropriate use of real-world data, which will be discussed now by Dr. Hubbard, really requires rigorous methods. So I'm really excited to pass the baton over to Dr. Rebecca Hubbard to take us through the next portion of this talk.
Great, thank you, Dr. Mamtani. That was an excellent introduction to the opportunities for using real-world data and electronic health records data to advance research and advance our clinical decision-making. I'm now going to delve a little bit deeper into some of the methodological issues so that you can get a sense of the challenges that arise and how we can start to overcome them using advanced methodology to really make the strongest possible inference using these novel data sources. This is a depiction of the process of a patient interacting with the healthcare system. And it's really important to think about this process as we start to consider using EHR and claims data for research, because this is essentially the data generating mechanism that creates the database that we'll then be analyzing in our studies using real world data. Typically, if we were conducting a traditional observational study or a clinical trial, we as researchers would pre-specify the timing of patient observation, the measures that are collected at each of the study visits, and so on. And all of those characteristics would be specified by us as researchers in order to give rise to a data structure that supports answering the questions that we want to answer with that data set. When we start to do research using real-world data, we are no longer in control of that data capture process. So rather than pre-specifying the study visits that we need, the data elements that we need in order to be able to ask the questions that we want to ask, instead, we're relying on the data that have been generated through the routine interactions between the patient and the healthcare system. So as illustrated in this figure, here we have one single patient who has a series of encounters with the healthcare system of different kinds. They're making primary care visits. Later in time, they have a hospitalization. And at each of those encounters, we have different data elements that are collected. So at one visit, their hemoglobin A1C is tested. At another visit, their creatinine is collected, and so on. So if we take these data generated through the interactions between the patient and the healthcare system, and we restructure them into a database that we can use for research, what we end up with is something that looks a lot like any other longitudinal observational database that we would use for research, except unlike those traditional databases, in this one, the series of data elements that are available, the timing of the collection of those data elements is going to be completely heterogeneous across patients, because each patient is going to have their own unique series of encounters with the healthcare system. The timing is going to be different. The data elements that are collected are going to be different. And so a lot of the assumptions of standard statistical methods that assume, for instance, independence of the disease process that we're studying and the process of collecting information about that disease process, those types of assumptions are going to be violated. So we need to think carefully about this data generating mechanism and make sure that we're using methods that are appropriate for analyzing data that have been collected in this way. When we start to conduct research using EHR data, there are a number of sources of bias that we need to consider. And I generally think of those sources of bias as being divided into those that are arising due to information bias and those that are arising due to confounding. So sources of bias that I would classify as information bias come up due to the error, the misclassification, the imperfections in EHR data. And as my slide says at the bottom here, a lot of those sources of error we can think of as arising because the data were not collected for research purposes. So in a traditional designed research study, we have very precise specification of how we want each characteristic measured, how we define a specific outcome and exposure, and so on. Whereas in the context of research using EHR claims data, that's going to be ad hoc. It's going to vary across providers. Different clinicians will have different practices in terms of how they specify a particular diagnosis or a specific exposure or confounder variable. So when we extract data from EHR, there's going to be measurement error and misclassification. There's going to be lack of harmonization, so lack of standard usage of terminology across records. And as Dr. Mamtani had mentioned, we can divide EHR data into both structured data and unstructured data. Structured data, which typically consists of codes such as diagnosis and procedure codes, are easy to use because all providers in the health systems that we're deriving data from use a common set of codes. But those codes tend to be coarse and non-specific. They don't necessarily coincide perfectly to the research concepts that we'd like them to be encoding. So we have rather messy, imperfect data giving rise to information bias. And then additionally, in any observational research, we always have to worry about the risk of confounding. So in the context of EHR data, confounding is particularly problematic because we have limited information on some of the confounder variables that are really quite important, including behavioral risk factors and social determinants of health. So those pieces of information just are not collected very well in EHR data. If we're willing to mine the narrative text data, so delve into the unstructured data, we can sometimes extract some of those pieces of information, but because they are not systematically collected for all patients, they're going to be inconsistently available. And as a result, we get back to the problem of information bias now in terms of error in our confounders, leading to incomplete confounder control, and in that way introducing residual confounding bias. Additional information on things like symptoms, family history, and disease severity are inconsistently available and may not be available in the kind of high quality form that we really need for research. So overall, there are a lot of potential sources of bias that we need to be aware of and need to be thinking about how we can best address so that we reduce the risk of bias in our analyses as much as possible. All of the complexity of EHR data and these risks of bias that I just discussed really motivate my interest and the need for advanced methodology in this context. So as I just discussed, there are many potential sources of bias in EHR-based studies. At the same time, we can potentially assemble very large databases for conducting EHR research. So some EHR databases include tens of millions, or in a few cases, even hundreds of millions of patients. From a statistical perspective, when you put together a data set of that size, it gives you the potential to estimate the quantities that you're interested in with very, very high precision. So very, very high precision corresponds to very, very low variance. It means if we repeated this estimation procedure multiple times, we would come up with the same answer over and over again. And in terms of the way that we express uncertainty, we would say we're very certain, we have a very narrow confidence interval around that estimate. So we can cross-classify bias and variance to characterize our estimates. And I've illustrated that on the right-hand side of the slide with bullseyes. So in the context of EHR-based research, because of the high risk of bias, coupled with the large sample size, which allows us to generate low variance or high precision estimates, the case that we find ourselves in is the lower left-hand case, where we're generating potentially highly biased, but very low variance estimates. That is a very troubling quadrant of this cross-classification to be in, because it means that we're generating estimates that we're claiming to be very, very certain about, and yet our estimate is fundamentally off target. It's discrepant from the true parameter that we're trying to estimate. So in this context where we have the potential to generate very low variance estimates, it's particularly critical that we harness whatever methodology we can to reduce the bias, to move that cluster of points back towards the center of the bullseye as much as possible, to ensure that we're generating low bias, low variance estimates rather than high bias, low variance estimates. So what I really focus on is how we can make that transition. How can we move our estimates from EHR-based research back towards the center of that bullseye? I'm going to present one example of a methodological study that Dr. Mamtani and I worked on together that investigates approaches to combining information from trials and real-world data, and uses a few statistical, advanced statistical methodologies to try to accomplish this. So what we would like to do here is leverage the information available in EHR and take it and couple it with information from clinical trials to make this explicit comparison of patient outcomes in the trial context to patient outcomes in the EHR. And the question that we're asking there is whether patients receiving the same treatment as patients treated in the clinical trial, but now treated in the real world, experience comparable outcomes. In order to do this, what we're going to do is use individual level patient data extracted from the EHR. And we're taking the perspective of assuming that we're independent researchers. We are not part of the sponsor that conducted the trial. So we don't have access to individual level patient data from the trial. But what we do have are all of the aggregate data that the sponsor of the trial has published. So typically, if you read a paper reporting results of a new treatment for cancer, what you'll see are outcomes reported in the form of Kaplan-Meier plots. So an example of a Kaplan-Meier plot that we used for this specific study that I'll mention on the right-hand side of this slide. And it's telling us about the survival of patients over time receiving the treatment that we're interested in. And then we'll have information about the characteristics of the patients participating in the trial in the form of what we call in statistics the marginal distribution of the characteristics, which means in usually a typical table 1, you have the mean and standard deviation or the frequencies and proportions of each of the characteristics reported individually. So for each characteristic, we know what the distribution looked like for the trial patients, but we don't know what the joint distribution, if we were to look at how those characteristics co-vary together, we don't know what that joint distribution looks like. So in order to make this comparison between outcomes in the trial and outcomes in the real world, what we need to do is first create individual level data from the trial based on what we're able to access in the form of the Kaplan-Meier curve that's published in the trial publication. In order to do this, we use an approach called survival data reconstruction, and this consists of 2 steps. So in the first step, what we're going to do is take the curve that's been published, and I have an example Kaplan-Meier curve on the right-hand side of this page. And we're going to use an approach called curve digitization, which essentially uses a computer to trace that curve and extract from each point on the curve the set of coordinates that describe the time and the survival probability at that time. Then using that numerical form of the information that's encoded in this plot, we're then going to use an algorithm that reconstructs the individual level data from that information, essentially by looking at that curve and noting that each time the curve drops down, that represents a point in time at which an outcome has occurred. So we can impute that at that point in time, there was an event. We then need to distribute the censoring times across the follow-up period. And the algorithm does this first by just distributing them evenly over all of follow-up. And then what we'll do is check and see if the number of patients still in the risk set at different points in follow-up, based on that even distribution of censoring times, corresponds to what has been reported in the paper. So in my curve on the right-hand side of this slide, down at the bottom, I have the number of patients at risk at each 6 months. So after we distribute our censoring times, we can compare the number of patients in the risk set based on that distribution to the number of patients in the risk set reported at each 6 months and see if they agree well. If they match up, then we know that our individual level data has been constructed well. If there are discrepancies, then we revise the distribution of the censoring times, update the individual level data, and compare again. And we go through this process iteratively until we have individual level data that corresponds to both the curve and the number of patients at risk reported in the paper. As you can imagine, this process is not perfect. It's going to introduce some error into the reconstruction process. That error is going to be proportional to the amount of censoring, because for the censoring times, we're basically making guesses about when they occurred. And it's also going to be dependent on the density of auxiliary information on the size of the risk set. So here I've given an example where we have that information every 6 months. In some studies, it would be reported more densely than that. In other studies, they might only tell you the number of patients at risk at the beginning of follow-up and possibly at the end of follow-up. The denser that information is, the more accurately we can try to update our distribution of the censoring times, and the better our survival data reconstruction will be. So the first part of this project was actually a methodological investigation I'm not going to present, essentially ensuring that we could use data created in this way to compare trial and EHR outcomes without introducing a lot of bias. And we found that this actually performs very well. The next step in our comparison of EHR and trial data is to try to account for confounding by balancing the distribution of patient characteristics between the trial and the EHR. And the way that we're going to do this is by using weighting to create a pseudo-population where the characteristics are balanced between the two populations. So I have a very simple example here on in the figure, where I'm illustrating one single patient characteristic, which is color. The people in my trial population and my EHR population are either blue or purple. And let's say that purple corresponds to patients' risk factors that give rise to a prognosis. So the purple people perhaps have poorer prognosis than the blue people. In that case, this difference in the distribution of this patient characteristic between the two populations would give rise to confounding when we go to compare our trial and EHR populations. So what we need to do are find weights, which when applied to the EHR sample, give us a pseudo-population in which the distribution of purple and blue is balanced between the trial and EHR populations. So I think that's very straightforward to see in the case of one characteristic. It becomes more complicated when you're trying to simultaneously balance multiple characteristics. But essentially, we can construct an algorithm that finds a series of weights that, when applied to the EHR population, balance all of their characteristics relative to the marginal distributions of the characteristics reported in Table 1 of the trial. We took this approach and applied it to a comparison of trial patients and patients from the Fire and Health EHR Oncology database who were treated with gemcitabine carboplatin for bladder cancer. So our objective here was to try to find an EHR population that resembled the trial population to the extent that we were able to harmonize those characteristics with the available EHR data, and then to apply this methodological pipeline to see if outcomes in that real-world data set were similar to those observed in the trial. The first thing that we needed to do was apply the inclusion-exclusion criteria from the trial. And this is a setting where we again see the role of information bias in analyses of real-world data. So one of the inclusion-exclusion criteria from the trial was that the patients were cisplatin ineligible, which was defined as having performance status greater than or equal to 2 or impaired kidney function. In real-world data, performance status information is often missing, and kidney function isn't assessed in the same consistent and harmonized way across all patients, as it would have been in the trial. So to identify kidney function, we used data on GFR when it was available. When it wasn't, we looked for ICD codes for chronic kidney disease. And we know right off the bat that that's potentially going to introduce some discrepancy between the trial and EHR populations. We did this and were able to construct an EHR population with 330 people in it. And we compare that to the trial population, which had 119. If you look at the distribution of the patient characteristics between these two populations, they're quite similar with the exception of performance status. So for performance status, we actually see somewhat unexpectedly that the EHR population has better performance status than the trial population. So we see about 28% of individuals in the Flatiron population had performance status 0, which is the best performance status, and only 17% of patients in the trial population. So that's one of the characteristics that we would need to make sure that when we apply our weights is going to be balanced between the two populations in order to avoid introducing confounding. We applied the approaches that I described, and the results of that analysis are presented on the right-hand side of the slide. The gray curve represents the reconstructed trial survival probabilities. The blue curve gives the unweighted Kaplan-Meier curve for our EHR population. And then after applying weights to balance the distribution of all the observed patient characteristics, we get the red curve. If we compare the trial and EHR populations using a Cox proportional hazards model, we come up with a hazard ratio of 0.88, comparing the EHR to the trial. So in other words, that's telling us the survival of the trial population patients was a little bit better than, did I say EHR? The comparison there says that the EHR patients are surviving a little bit better than the trial patients. And then after we apply our weights, we see that it moves a little bit closer to 1. So we get a hazard ratio of 0.93, saying that after weighting, after balancing the patient characteristics between the two populations, the EHR population still has slightly, non-statistically significantly better survival than the trial population. So that pattern that we've observed could be attributable to a number of different things. There could be slightly better observed survival in the EHR population because of residual confounding by characteristics that we weren't able to access. It could be attributable to imperfect outcome ascertainment. As Dr. Mamtani said, we know that we do not have perfectly accurate capture of survival in the real world data. Or then finally, it could represent real differences between the two populations. So there might genuinely be differences why treatment in the real world setting has slightly different outcomes than treatment in the trial setting. Finally, I just wanted to note a couple places where we have opportunities to improve the quality of inference based on EHR data using advanced methodology, particularly using deep learning, which is a type of machine learning method. So we're currently pursuing 2 methodological investigations to use deep learning to improve the quality of our studies. The first is trying to account for that heterogeneous process of data generation, which gives rise to complex missing data patterns using an approach called denoising autoencoders. So the right-hand side of this slide is an illustration of a denoising autoencoder. And this is a type of neural network that takes a corrupted version of our inputs, a corrupted version of our data elements, applies this neural network to it, and uses that to try to predict the original uncorrupted inputs. So what we do is take the data for our sample who don't have any missingness, corrupt that data, try to predict the original data, and then use the neural network generated through that process to make predictions for the individuals with missing data. So that's one approach. An additional approach that we're currently looking into is the use of feed-forward neural networks to try to encode information from big but messy EHR databases in a lower dimensional representation. A lower dimensional representation means we create a smaller number of derived variables that encode all of that information. And we can then incorporate that into a trial analysis, which possibly has access to just a smaller database where we can't use as many variables. And so we need to represent it more concisely. All right, just to wrap up quickly, there are many opportunities for using EHR data to extend the inference that we can make in trials. But EHR data are messy. They were not created for research purposes. So we need to think carefully about confounding control And additionally, I think very importantly in the real world setting, we need to think about those sources of information bias, because confounders themselves may be missing or error prone. And the heterogeneous nature of the data capture process just means there's going to be a lot of messiness, missing data, and measurement error. The approach that I described to survival data construction appears to be an effective way to allow us to examine and compare differences between trials and EHR, but there are a number of remaining challenges, including harmonizing inclusion and exclusion criteria, addressing confounding when those confounder variables are not captured well in the EHR, and then finally, that imperfection in our outcome information, so the lack of perfect accuracy in the survival data. So all of those things taken together mean real world data are challenging. They definitely require methodological innovation, but there's an enormous opportunity for improving the quality of clinical decision-making and extending the types of conclusions that we can draw to populations that are underrepresented in trials. Finally, I just want to acknowledge the work of my collaborators at Penn, particularly Kylie Getz, who's the student who worked on the survival data reconstruction project that I described, as well as the financial support of the NIH. And I want to thank all of you for your attention, and Dr. Mamtani and I are happy to answer questions.